Hi, my name is Kristina Paterson. I'm the founder of Mothers Helpers, and I'm going to talk to you about the gaps experienced by women in New Zealand who have had perinatal depression and anxiety. So I'm just going to share my screen with you and a PowerPoint presentation. Okay. So firstly, a little bit about me is that I worked as a registered nurse for 15 years, mostly in the paediatric nursing, community nursing and education fields. I have experienced both antenatal depression and postnatal depression and anxiety. They were not picked up for 18 months, and that was around the time that my son was born. I founded Mothers Helpers in 2011, so it's a charitable trust that has been going since then, helping women to recover from perinatal depression. And I'm author of the Perinatal Depression Steps to Recovery program, which has now been renamed as Out of the Fog. I've got a master's in applied social work, which I received from Massey University, and I'm a registered social worker. I also presented a petition to Jacinda Ardern and David Clark in 2017 on behalf of Maternal Care Action Group. So in terms of the prevalence of antenatal and postnatal depression and anxiety, we know that 1 in 8 women experience antenatal depression, and that's from a Growing Up in New Zealand study and carried out in 2015. And we know that 1 in 5 women experience postnatal depression and anxiety. The onset of postnatal depression is from birth to 6 weeks postpartum. It's seen to be the most vulnerable time. So essentially, the most vulnerable time for a woman during the perinatal stages is pregnancy and first 6 weeks. It doesn't mean that she won't or could not develop postnatal depression later on. It just means that that is the most prevalent time. So the recommended treatment for perinatal depression and anxiety, and these are best practice guidelines, is diet, exercise and therapy for mild depression or anxiety. So for GPs, their best practice guidelines is to offer therapy in the first instance prior to offering medication, and that they should be advising on diet and exercise, because these 3 things are seen to be effective for mild depression or anxiety. It is an ethical dilemma for GPs if funded therapy is unavailable. So currently we are in the process, it's 2020, we're in the process of change, and we are hoping to have more access to funded therapy. But if that access is not available, and best practice guidelines suggest that GPs offer therapy in the first instance, that's a real ethical dilemma if there's no funded therapy available, or very limited funded therapy available, in terms of following best practice, but also doing what actually the client can afford. The next step is medication, but what's important, that's for moderate to severe depression or anxiety. What's really important though is to acknowledge that medication alone is not recommended, that a combination of medication and therapy is recommended, and this is seen to be the fastest way to recover from depression or anxiety. And there is an acknowledgement that mental health is an illness that has resulted in a combination of holistic issues, and therefore that holistic treatment and holistic well-being is needed in order to recover or become well. So the Mothers Helpers PND survey results. Mothers Helpers carried out 2 surveys in the last 5 years. The first survey was done in 2015 and the other was in 2019. It was a snapshot of the experiences of women, and 100 mums participated in the 2015 survey and 100 mums participated in the 2019 survey. So respondents had to have had PND between 2007 and 2013 to participate in the 2015 survey. They had to have postnatal depression or perinatal depression between the years of 2014 and 2019 for the 2019 survey. So the risk factors. So we found that in the 2019 survey that 96% of the women actually had possessed risk factors. In the 2019 survey, 99% had risk factors. Mothers said that they started experiencing symptoms during pregnancy or in the first week after baby's birth. It was 63% in 2015, 83% in 2019. So that was that vulnerable stage that I was talking about earlier. However, only 19% were diagnosed during that time in 2015 and 29% in 2019. So 2/3 of women are still experiencing delays in diagnosis. So despite releasing these survey results in 2015, and which actually went on to television and news and media and so on, we found that there was no significant change in our next survey in 2019. So I'm just going to see if I can play this news clip. Sorry, just bear with me a moment. Try again. To see if that's going to play. Here we go. Start from a bit further back.
Women are speaking out about postnatal depression to help more mothers get the treatment they need. A charity provides support for new mothers on distress before they have been diagnosed. Health correspondent Lucy Marcus reports.
Okay, so just going back to our slides. Yeah, so you can see from there that that was a news story that we did when we released our 2015 survey results. What didn't make the news is that the survey results in 2019 had not improved. So that was really sad to discover that. So again, with the PNDA survey results, we asked about information, and in 2015 we didn't measure this, but we were really interested to find out whether women were actually getting information about antenatal depression. And in 2019, women said that 18% received information about antenatal depression in their antenatal class. 19% from their midwife, 14% from their GP, and 9% from their well child nurse, which, as we know, they don't see their well child nurse until after a baby is born. So 69% said they were never informed about antenatal depression during pregnancy, and yet we know 1 in 8 experience antenatal depression, and we know that 2/3 of women were experiencing antenatal depression during that pregnancy or first 6 weeks postpartum. In 2015, just 40% of women heard about postnatal depression from their midwives, 30% from Plunkett, and 35% from their GP. In 2019, 61% from antenatal class, 53% from their midwife, 42% from their GP, and 61% from their well child nurse. So we can see that information is improving for postnatal depression, but information is still massively lacking regarding antenatal depression. So with regards to assessment, and with assessment we're talking about any assessment tools, for example the Edinburgh scale or the PHQ-2 with the 3rd question. So an A&D assessment during pregnancy in 2019, 25% said that they received an assessment by their midwife and 18% by their GP. 61% said that they were never assessed during pregnancy. So postnatally, in 2015, 28% said that they were assessed by their midwives, 39% in 2019. For well child nurse, so that includes tamariki ora and Plunkett, 21% in 2015 and 27% in 2019. I was really, really surprised by these results because I'm aware that there is, that for Plunkett, they adopt the PHQ-2 plus a 3rd question to assess women for postnatal depression. So I was really surprised by those statistics, and I'm not, I don't have any information as to any insight as to, whether it is that well child nurses are not actually carrying them out, or whether it's the woman's perception that they're not carrying it out, or what that story is. So for 2015, GPs assessed postnatally, 43% said, and 24% in 2009, which again I was surprised by, that has actually decreased. In 2015, 34% said no one assessed their symptoms, and in 2019, 41% said no one assessed their symptoms. So that has actually worsened. So the consequences of postnatal depression, and the reason I'm just sharing the consequences in 2019 is because they are nearly identical to the results that we got in 2015. So 57% said they had marriage or relationship problems. 9% resulted in relationship marriage breakup through separation or divorce. 55% had difficulty bonding with baby. 95% experienced overwhelming anxiety and isolation. 86% experienced guilt and low self-esteem. 87% said irritability or moods affected their friendships and relationships. 51% were unable to carry out basic cares for themselves. 11% were unable to carry out basic cares for their baby. 46% had thoughts of suicide. 16% had thoughts of harming baby. 12% self-harmed. 4% attempted suicide. 39% shouted at baby. 4% physically hurt baby. 8% were hospitalised in a psychiatric unit, and 1% had OT, had to take baby for a time. So it's really probably a really good idea just to pause and reflect on the consequences of PND, and to note that these consequences worsen for women the longer diagnosis and treatment is delayed. So in 2000, so we asked what the women felt were the gaps that they felt the most. And in 2015, 59% said that there was insufficient practical support. So that's things like childcare and housework and things like that. And for many of the women that I work with, there's often no family support, and that's definitely a risk factor for women. So yeah, insufficient practical support was seen as a really important gap. 73% in 2019 said the same. In 2015, 41% said there was insufficient information prior to birth. In 2019, 66% said this was an issue. In 2015, insufficient information about help or resources available. 58% said this was the case, and 60% said the same in 2019. 44% said insufficient monitoring of my depression was an issue in 2015, 55% in 2019. 38% said no one was screening or assessing me for depression or anxiety in 2015, and 54% said that was the case. 41% said they were not given a full range of treatment options, and 48% in 2019 said the same. So in 2019, 47% said they were unable to access funded counselling. We didn't ask that question in the 2015 survey. In 2019, 43% said no one was referring me for help when they identified I was at risk or experiencing depression or anxiety. This was a question we didn't ask in 2015. In 2015, 37% said there was insufficient information after birth, and 43% in 2019 said the same. And in 2015, 41% said no information on where to go for help if I need it, and in 2019, 42% said the same. So the consequences of untreated A&D and PNDA, this is what the research says. So for mum, there's a risk of increasing severity of depression, a potential for hospitalisation and separation from child, since we have limited mother and baby units in New Zealand. There's increased risk of development of psychosis. And there's increased risk of developing chronic depression. Still with mum, there's an increased likelihood of substance abuse, pregnancy-induced hypertension contributing to preeclampsia, gestational bleeding, diminished uterine artery blood flow, and poor birth outcomes, including fetal death, preterm birth and labour, small infants for gestational age, low birth weight, low APGAR scores, and increased risk of neonatal special care and intensive care admissions. And of course, there is an increased likelihood of suicide. And in fact, the leading cause of maternal deaths in New Zealand is suicide. So for the partner, there is a risk of a breakdown of the family unit. There's also a risk of a partner developing what's called partner depression. So that is depression that you might develop if your partner is experiencing mental illness. For the child, with antenatal depression or anxiety, there's an increased risk of emotional, cognitive, and physical development issues when a woman is untreated for antenatal depression during pregnancy. For postnatal depression or anxiety, there's an increased risk in insecure attachment. And many of you will know what that means, but we will touch on that now as well. So insecure attachment puts a child at increased risk of learning difficulties, mental illness, delinquency, addictions, relationship issues, and suicide. So when we are looking at things like suicide prevention, it's my absolute belief that prevention starts from pregnancy. So pregnancy in the first 3 years of a child's life is the most crucial time in their life and can determine outcomes not only as a child, but also later in life as an adult. So when we talk about our high youth suicide rates and our overall high suicide rates, and we're looking at prevention, we need to be starting with pregnancy in the first 3 years of a child's life. Otherwise, we are neglecting our duty of care. So I want to tell you a wee story about a woman by the name of Melly. So Melly came to Mothers Helpers service. She, her eldest child was 6 years old and she had 4 children by this stage. Melly, for the first time, had actually trusted Mothers Helpers to tell us how she actually was feeling. And when we tested her Edinburgh score, it was showing the highest score that at that time that I'd ever seen. It was a score of 27 out of 30. I've since seen worse Edinburgh scores, but at that time that was the highest I'd ever seen. She was experiencing suicidal thoughts every single day. She had been living with these symptoms since the birth of her first child, so for 6 years. And we were able to help Melly, so we were able to get her in touch with the crisis team and mental health services, but she also engaged in our recovery program. And consequently, by the end of the 12-week program, she had a normal score of 7. So that's a really good news story in terms of the outcome of that. But for 6 years, Melly went untreated and undiagnosed. And I want you to think about how many, with 4 children over that 6-year period, how many midwives she came in contact with, how many nurses, doctors she came in contact with, how many well child nurses she came in contact with, how many health professionals she would have seen over that period of time, and no one had picked up that she had depression or anxiety. So sorry, going back to that slide, early identification of antenatal postnatal depression or anxiety significantly improves outcomes, and early detection of depression, and specifically postnatal depression, is widely not acknowledged as best practice. So why are there delays in diagnosis and treatment? So the Midwifery Council have said that the most commonly chosen lead maternity carer during pregnancy and up to 6 weeks postpartum, remember that is the most vulnerable stage for a woman to develop antenatal postnatal depression or anxiety, are midwives. So the most commonly chosen lead maternity carer during that vulnerable stage are midwives. I completed some research for my master's that was trying to answer some of these questions, trying to get to the bottom of why midwives may not be picking up or getting helping women to get access to help. So one of the reasons that I found was that midwives were not screening. There were low screening rates and low referring rates, was that it was due to a lack of knowledge. And this research was in keeping with the findings of an extensive piece of research in Australia, where they actually were surveying or researching 800 midwives that participated in that study. There's other research that has found that midwives don't refer women because they don't believe that the right help or treatment is available. So, for example, women not meeting criteria for maternal mental health, and that there has not been available funded talk therapy. So what we know is that that approximately 11,000 women experience perinatal depression or anxiety every year in New Zealand. Unfortunately, 75% of them will not meet the criteria for maternal mental health. So best practice guidelines suggest that talk therapy should be offered in the first instance for mild to moderate depression, and that's for the 75% who experience mild to moderate depression or anxiety, and that should be offered alongside medication treatment. Research says that the combination of medication and therapy promotes a quicker recovery than medication alone, and a more recent study has shown that 12 weeks of CBT or cognitive behavioural therapy was more effective for women with perinatal depression or anxiety than 12 weeks of medication alone, or even 12 weeks of combined CBT with medication. However, only funded medication is available in most cases currently, and if funded counselling is available at the moment, it's usually no more than 4 sessions via their PHO or primary health organisation. We are hoping that we are in a stage of change where more funded talk therapy will be made available this year and in the coming years. 42% with PNDA said they access talk therapy despite access talk therapy despite 93% wanting talk therapy. So that should read that they could not access talk therapy despite 93% wanting talk therapy. The 42%, sorry, I've just let me say that again. I've just understood what I've got here. So 93% were wanting talk therapy, but only 42% accessed it. A better way of putting it. And the 42% that accessed it had an average of only 4 sessions, largely due to funding or cost. So that will be the 4 sessions most likely available through their PHO. When there is a preference for talk therapy by women with PNDA, especially during pregnancy and breastfeeding, due to perceived effects on baby, This creates a barrier to women reaching out for help because they don't believe that funding or help is available to them. The Mental Health Inquiry report in 2009 said this: a strong theme from submissions was that prevention must engage more fully with life course theory and that child-centred early intervention service delivery is insufficiently embedded into current mental health and addiction services. There is a striking degree of consensus about the need for change and a new direction, an emphasis on wellbeing and community with more prevention and early intervention, expanded access to services, more treatment options, treatment closer to home, whānau, and community-based responses and cross-government action. So what are the barriers to care? We've talked about some, but let's if you're using this slide for any teaching sessions, I would encourage you to stop the PowerPoint now and discuss what are the barriers that you're aware of to women getting help. But let's also go through them now. So first of all, stigma. We know that the stigma is improving in the sense that we're getting more and more willing to talk about mental illness, depression and anxiety in society. However, one thing I would say about about mothers is that there is a real pressure to be seen to be coping. There is a real pressure to be winning as a mother, to be really managing this thing, for being an expectation for being the super mum and being able to pull it off. And some of that kind of pressure is promoted through things like Facebook culture, where we just report we tend to report on just the things that we succeed in and not the everyday difficulties and challenges. So a lot of mums don't feel like they can be honest about how challenging they're finding motherhood, and let alone to be talking about symptoms of depression or anxiety. Sometimes lack of childcare can be a real issue, especially if a woman is trying to access therapy and the therapist has said that it would not be appropriate for them to bring their baby with them. And to be fair, that's for the purpose of making sure that she can focus on the therapy rather than spending that time dividing her focus. Finances are obviously an issue if funded therapy is not available. Poor past experiences with healthcare providers, language barriers, and we need to remember that the prevalence of perinatal depression or anxiety is higher amongst Asian people. We expect that the research shown in the UK that new immigrants have a higher rate of perinatal depression or anxiety would also be the same here in New Zealand. So new migrants, that would be relevant to them too. But also our Māori and Pacific cultures, and there is some research to say that some Pacific cultures are more at risk of developing PNDA. Failure to recognise their own symptoms. So at the moment we've had a national depression initiative, and that national depression initiative has the expectation that there's health promotion around depression and anxiety, and that may be used, for example, it may be television advertisements as an example. Some of the John Kerwin ads and some of the the website that he promoted was part of that National Depression Initiative and health promotion. The idea is that upon receiving information that people get help for themselves, that they take responsibility for their own mental well-being and access help once information is shared with them. The trouble with that, there's two issues with that. First of all, is that we just saw from a survey that information, particularly around antenatal depression, is really lacking. So women are not hearing about, especially antenatal depression, they're not hearing about that, and yet they're expected to help themselves. Again, with antenatal or postnatal depression. The second issue is that when you have depression or anxiety, it's very difficult to even identify what's really going on for you, let alone problem solve it, and to overcome all of the stigma and then reach out for help. So especially when there's low motivation as one of your symptoms. So the whole idea of the National Depression Initiative is problematic. And health providers' lack of understanding of the condition. So, you know, in my research, I was able to identify that there is actually, even amongst midwives, that there is actually a lack of understanding and knowledge around this issue. So more barriers to care. So women's inability to disclose their feelings. The perception that family members and health professionals had a reluctance to respond to their mother's emotional and practical needs. So in other words, sometimes we're very good at saying, asking the questions, but our whole body language, and in fact probably our inner attitude, if we're honest, is please don't say yes to my questions, because then I'm going to have to do something about your mental health. So when we have that kind of, and that's a very natural reluctance to have, especially if we're not experienced with dealing with mental health, or talking about these things make us feel uncomfortable as health professionals, you can absolutely be sure that your client picks up on that. And so if they're reading from you, don't tell me yes, they won't tell you yes. They're more likely to disclose their feelings to a health professional where they pick up that, that there is no reluctance to respond. Lack of knowledge about postnatal depression and acceptance of myths meant women found they were unable to identify symptoms of PND, and barriers around health services. We've talked a little bit about access issues. Preference for non-judgmental talking therapies and pharmacological interventions. So many women say to me that they don't, and I was actually one of these women, who have said that they don't want to go to the doctor because they don't want to be put on medication. And that has been their only, they feel that that's the only option that has been given to them, or perhaps the only affordable option. Okay, so this is another study. It talked also about stigma, and that barriers to care included fear that others would think they were not doing a good job as a mother, which we've already talked about. There was no ownership of mental health concerns of women among the various health providers during the perinatal depression period, or the perinatal period, sorry. And that is absolutely true, that at the moment there is no one really owning that. There is an expectation that mental health, mild to moderate perinatal depression or anxiety, is managed in the community. And that is supposedly meant to be including, or mostly to be put onto the GP, which is, you know, a GP has very limited resources available to them beyond funded medication. Until the day that we have funded talk therapies and other options available, which we hope will be rolling out over the next few years, then that no ownership does continue. There's no mandatory screening expected of midwives, and there's no, even though we've got best practice guidelines for GPs, you know, these surveys indicate that certainly best practice isn't always being followed. And then no one notices their risks or their symptoms. A lack of knowledge and awareness demonstrated by health providers, and when symptoms were identified, the only treatment option presented was medication, as well as fear of medication. So this is, if you're doing a teaching session, this is a good time to pause your video and ask, what can we do to reduce the barriers? So that is a really good discussion topic for those of you exploring this and wanting to discuss this a bit further. Next question, and you may want to pause the video again to discuss. What can we do to detect depression or anxiety early? And third question, what can we do to ensure early diagnosis and intervention? So this is a study too that looks at what helps to reduce the barriers. So first of all, comprehensive maternity care is the enabler that facilitated help-seeking behaviour. Identified this as a system that addresses the biological, psychological and emotional needs of the mother-baby dyad. This included open teaching and dialogue about mood disorders, including universal screening of all women as part of routine perinatal care. It also included treating the mother-baby dyad as a single unit so that mothers felt equally as valued as their infant. There is a real need for clearer referral pathways, better funded services, especially talk therapy. And this is from the Ministry of Health in 2008. There is evidence that postnatal depression is inadequately recognised and treated in New Zealand. In view of the potentially very serious consequences of failure to identify mental disorder in women in the antenatal or postnatal period, a policy of targeted screening for mental disorders in all women in the antenatal or postnatal period is recommended. At a pregnant woman's first contact with primary care, at her maternity care booking visit and 6-week postnatal check, practitioners should consider asking questions that screen for depression as part of routine assessment. So going back to the problem, and I've already stated this, but just going over that again, the single leading cause of maternal deaths in New Zealand is suicide. New Zealand's youth suicide rates are the highest in the developed world. We can't say that we are engaged in prevention and early intervention if we are neglecting to adequately care for 75% of mothers experiencing mental health issues. So where to from here? Can I encourage you in your role to inform women about antenatal and postnatal depression and anxiety? Encourage honest conversations. Be a safe place for her to confide. Have empathy. Reassure. Praise her for her honesty. Allay fears to reduce any shame around seeking help. In other words, be a safe place for her to confide. And screen. Screening that I would recommend as one of the best tools, and that's used and recognised internationally, is the Edinburgh score. It is a very simple tool to use, and Mothers Helpers has a link that you can give to your mothers for them to fill in because that's how the Edinburgh scale is carried out, or the Edinburgh scale. And it scores it for you. So it actually gives you the score of, as well as the results of the questionnaire. And that goes into the mother's email. And refer. So if she's got, if the Edinburgh score is indicating a moderate to severe Edinburgh score, so anything that's a 17 and above, refer through to maternal mental health. You're welcome to refer anybody through to Mother's Helpers, whatever their score is, because if you're worried about the risk factors that she possesses, but she's got a normal score, we will be able to still have a conversation with her, talk about preventative factors and monitoring. If she has a high score, we will assess her and we will offer her some treatment options. We will also refer her through to the crisis team or to maternal mental health or community mental health if she meets their criteria. So where to from here? For midwives or GPs, we have a Mother's Helpers referral partnership program. What that involves is that we offer free workshops to your staff delivered by Mother's Helpers with certificates. We have an agreement with you that you will carry out universal screening, ideally using antenatal risk questionnaire as well as the Edinburgh questionnaire, and referring to Mother's Helpers all women antenatally and postnatally if mum consents under our criteria. And our criteria is very flexible. So we take women who have children up to the age of 4, and we take women who are pregnant as well. For GPs, it's a commitment to regular recalls to invite women for screening. So for example, if you're using MedTech to do a MedTech inquiry and to put out recalls for that screening to occur with your practice nurse. Some practices will be rolling out the new format of HIPs and health coaches. So again, we're really happy to provide training there and to for your staff, and to assist your staff in learning how to screen. So what that does for you as a practice is that whether you're a midwife or a GP or practice nurse, is that it saves you time. So screening can be done via a device while the client is in the waiting room. You also don't have to do that. Some people like the mother to be in their office while they're entering in that questionnaire. The link is there for you to pass on to your client. Referring to Mother's Helpers takes a few minutes. So Mother's Helpers will carry out a thorough 40 to 60 minute free assessment. We would refer to all eligible support services and communicate the outcome to you in a letter for you to put on file. It provides early intervention resulting in best outcomes and preventing unnecessary impact to the family. Your clients won't fall through the cracks. So just going back to that email address, we just ask you to contact us if you're a GP or you're a midwife and you would like to be part of that referral partnership program. We would love for you to join us. There is no fee involved. Just email us at info@mothershelpers.co.nz. So for counsellor and therapist or social worker, we are offering the training in the Out of the Fog program. So we have a new website launched called www.getoutofthefog.org. And on that website, training is available so that you can deliver the Perinatal Depression Recovery Program. It's now called, rebranded as Out of the Fog it's now available not only for women experiencing perinatal depression or anxiety, but for any adult experiencing depression or anxiety. And that program you can deliver if you're a therapist, a counsellor or a social worker. You can deliver that one-on-one, or you can deliver it in the context of group therapy. Okay, thanks for joining me, and please feel free to contact us at Mothers Helpers if you do have any more questions. info@mothershelpers.co.nz if you do have questions about the referral program for GPs and midwives. If you are a therapist, a counsellor, or social worker, and you would like to train in the recovery program that we now call Get Out of the Fog, please go to our website, which again is www.getoutofthefog.org. Thanks so much.